Welcome to podcast 4 in our series of 6 on leveraging public financial management for better health. Recorded in September 2019, it discusses the links between budget reforms and provider systems and looks at what is at stake.
I would like now to introduce our speakers. We are very pleased to welcome Elina Dale. Elina is a health financing specialist. Our second speaker is Lorraine Hawkins. Lorraine is an international consultant in health financing, health systems and governance who joined the Health Foundation as governor in 2017. Our third speaker is Cheryl Cashin. Cheryl is a health economist specializing in the design, implementation, and evaluation of health financing policy in low middle income countries, with a focus on health purchasing and provider payment for universal health coverage.
Good afternoon, everyone, and thank you again for joining us today. Without further delay, let me start. We hope that by the end of this webinar, you will agree with and can explain the statement on this slide. That is, the way public budgets are formed, allocated, dispersed, and accounted for influences how service providers can be paid in the health sector. If budgeting rules allow budgets to be created, approved, and controlled based on categories of outputs with a common objective, most payment method options are likely to be available. Before going further, let us clarify some key definitions, because lack of clarity in some of these terms has implications for policy reform design and interventions. Purchasing should be a familiar term to most of you, but just to reiterate, it refers to the allocation of pooled funds to public and private healthcare providers for the health services they provide. There is a growing evidence that purchasing of health services must be more active or strategic if countries are to make progress towards universal health coverage. However, purchasing can be often passive, where resources are allocated to providers in a public system without consideration of the services they provide or their performance. In this context, providers do not have strong or appropriate incentives to do better. Strategic purchasing means aligning funding and incentives with legal entitlements to health services, guided by information on provider performance and population health needs. Over the last 30 years, many low and middle income countries have sought to implement health financing reforms similar to those adopted in upper income countries. Specifically, the reforms attempted to establish a purchasing function or agency to allocate resources strategically to health providers. These reforms typically implied new provider payment methods based on output and population health needs, with the expectation that healthcare providers will be free then to adjust their inputs and to produce outputs more efficiently. Again, the expectation was that providers could freely adjust their inputs to produce outputs more efficiently. Payment methods, along with contracting and performance monitoring, are key instruments in purchasing. Provider payment method is the basis used to determine how much funding to transfer from the purchaser of health services to the provider. On this slide, you see 6 main provider payment methods. I won't read them all out, but would like to note that input-based payment is typically associated with a more passive approach. Also, terms such as line item budgets and input-based payments have often been used interchangeably, although they refer to different concepts and stages of the budget cycle. And as we see later, there are situations when a country shifts to performance or program-based budgeting, but providers continue to be paid based on input, and vice versa. Similar to strategic purchasing, program budgeting aims to promote strategic allocation of resources in accordance with public policy priorities. The focus shifts from strict input controls to accountability for results, although input controls are not abandoned. The question becomes who does it, at what detail, and whether it is done ex ante or ex post. As with strategic purchasing, the emphasis is on output and approve the shift between expenditures for office supplies and expenditures on communication and information, but instead monitors and reviews performance indicators of the line ministry, such as health. Program budgeting requires a change in the budget classification system, although it goes well beyond that and implies changes in the entire approach to management, as you may remember from the session in June. Budget classification system provides the overall framework for the way budgets are presented, approved, executed, monitored, and reported. Typically, multiple classifications are used to present budgets, as each classification has its own purpose. What matters, however, is the dominant classification, or classifications in some cases, used for appropriation, forming the basis by which the legislature approves the budget. As you may remember from June, economic classification is often associated with an approach to budgeting that focuses mainly on inputs and rigid appropriation management rules. However, in any efficient internal management and control system, accurate accounting and monitoring of inputs is required. If used for ex-ante external control of execution, this is called input-based payment. This graph illustrates how the concepts we discussed so far relate to each other. In other words, how budget appropriation structure and provider payment methods are linked. And with this, I hand it over to Lorraine.
Thank you, Alina. I would like to give some country examples of the points Alina has explained. But before I do that, to show you a little bit more about how this diagram here works, because I'm going to use it in my case study, let me just talk you through the diagram. This diagram tries to provide a simplified picture of the flow of public funds spent on healthcare services and the authorizations or decisions stages involved. To keep this example and the diagram simple, it's a diagram that shows a funds flow in a health system that has a single public purchaser or insurer that pools all funds for healthcare, and I'm assuming that this is an on-budget health purchaser that uses the public financial management system, the budget, and the treasury management system. The first step in the funds flow is the appropriation stage. That's the arrow at the top of the diagram, when Parliament approves the health budget for the purchaser. The second stage is the contracting and stage, where the purchaser agrees contracts with healthcare facilities over the services they provide, the payments the purchaser will make to them, and the conditions attached to payments. This is the string of arrows flowing down the right-hand side of the diagram from the purchaser to the providers at the bottom of the diagram. The third step in the funds flow happens after the providers have sent their invoices or claims to the purchaser. The purchaser then validates them and issues payment instructions to the Treasury to pay the providers. Finally, the Treasury executes the payment to providers. In some countries, the Treasury just pays automatically from the provider account, like any ordinary bank. In other countries, however, the Ministry of Finance or the Treasury Department carries out a further process of validation and control, ex-ante control we call it, before paying. I know that many of you will be from countries that have very much more complex health funds flow systems. Perhaps you have multiple purchasers or decentralized systems of government, but the principles and the processes involved are the same, and it will, I think, help to use this simplified diagram to bring out our main messages. When we look at countries around the world, we see some countries where all of those steps, appropriation, contracting, and execution, are aligned. They use the same classification. Some of them use output or program-based classifications all the way through. We also see many countries where different steps of the process use, all of the different steps of the process continue to use economic classification based on input line items. Perhaps the most common scenario we see in low and middle income countries is that different steps in the process use different classifications, or different funds flows in the system use different classifications. And that's when we get problems of misalignment between the provider payment system, the contracting system, and the public financial management and budget classification system. In this table, I won't talk about all of the countries. Let me just pick out some examples. First, quickly, Korea in row 2. They're a country that has program budgeting classification and output budgets under the programs all the way through, from the appropriation of the government budget through to the contracts that the provider writes with providers, the purchaser rights with providers, which use fee for service, pay for performance and case payment, and the execution of those payments to providers. A second example that's quite simple also is South Africa, where at the budget appropriation stage, the government uses program budgeting. South Africa doesn't yet have a separate purchaser for most of its health financing coverage, but the Ministry of Health directly manages providers. And although the Ministry of Health receives program budgets, it then converts those into line item budgets for each healthcare provider, and it executes payments to the provider based on those line item budgets. And it directly pays, there's a direct payment system for salaries. What you have in that system is that a budget classification system that really would allow strategic purchasing and pursuit of all of the objectives of program budgeting. But when it comes to the health financing system at the budget execution stage, the Ministry of Health, I should say, the Ministry of Health has not yet introduced the instruments of strategic purchasing, such as new provider payment methods. Let me now turn to Ghana at the top of the table. Ghana has a system that I would say is partially aligned. The government budget classification uses administrative, program and economic classification as the basis for appropriation. Some healthcare funding, notably the funding for wages of health workers, flows through this government budget and through this classification system. And so the payments to providers are direct payments for inputs. However, Ghana also now has a health insurance fund, which is an independent entity with its own budget law, and that health insurance fund can pay providers based on outputs using capitation and case payment. The health insurance fund can also execute its payments based on outputs. So the health insurance funds flow is internally aligned, but there's a misalignment between the health insurance fund payment system and the parallel system of paying for wages from the budget. The final example I'll talk about, also a common scenario. Philippines, in row 3, has a decentralized health system, but more recently, a health insurance fund has been established at national level. The local governments fund their healthcare providers from their own budgets using administrative, activity and economic classifications in their budget appropriation. They also use input line item budgets as the basis for paying their providers. However, the national purchaser, the health insurance fund, is off budget, and it is free to pay to set its budget based on outputs and pay providers based on outputs. But because the health facilities are mostly owned and directly managed by local governments, when the health insurance fund sends its payments to the local government to pay the providers, most local governments treat those payments just as another source of revenue to finance the government budget. And they then pay providers from that government budget based on input line items. Ghana, Philippines, and also Tanzania, which I don't have time to cover in detail, all suffer from misalignment because of fragmentation in their health funding systems. Providers receive 2 or more different flows of funds, some based on input classification and some based on program and output classification. This common pattern of fragmentation leads to a further key message for policymakers. Fragmented funding can undermine the benefits of provider payment reform, and it can also undermine the impact of program budgeting. This is illustrated by my swimming pool picture. If you fragment the swimming pool into lots of separate lanes, you can have maybe 8 or 10 swimmers in the pool at a time. If you take away the fragmentation into lanes and just have one big pool, you can accommodate, dozens, if not hundreds of swimmers in the same pool and achieve much more. Coming back to fragmentation in health, policymakers can address it in one of two ways. One is by actually pooling the fragmented funds flows into a single pool. But if that's not possible for political or legal reasons, an alternative is to align the classifications used for all of the different funds flows to providers. Use the same program classifications, the same output-based payment methods, the same performance indicators to providers for all funds flows. I now want to speak in a little bit more detail about a final country example, which is Kyrgyzstan. Kyrgyzstan implemented health financing reform beginning over 20 years ago with the establishment of a single national health insurance fund, which pools all public funding for healthcare. However, at that time, the Ministry of Finance had not begun to implement public financial management reform. So when Health Insurance Fund first tried to introduce output-based provider payment system, they ran into problems of misalignment with the public financial management system. This diagram illustrates the problems that occurred in phase one of their reforms. Parliament approved budgets using administrative and economic classification with very detailed line items. In step two of the funds flow, Health Insurance Fund contracted providers based on capitation for primary care, case payment for hospitals. But at the next stage of the budget, the Treasury executed the budget for providers using detailed input line items. And to make matters worse, the Treasury carried out ex-ante controls before it paid providers. It controlled each of those detailed line items each month before making payments. Providers therefore faced very rigid budgets, often leading to unspent funds in many line items at the end of the year. Those funds then had to be returned to the Treasury. This system obviously weakened the impact of the new provider payment methods. In practice, all that the provider payment methods were used for at this stage of reform was to set budget ceilings for providers during the budget formulation process. And while they redistributed funds in a helpful way, they did not create any positive financial incentives for providers. So in the second phase of reform in Kyrgyzstan, the Health Insurance Fund managed to negotiate with the Ministry of Finance to change the budget classification in a fairly small incremental way. Ministry of Finance wasn't yet ready to carry out a major program budgeting or output-based classification, but they did agree to amend the economic classification to introduce a new single line code which was used for the Health Insurance Fund budget. It now had just a one-line budget in the economic classification. This meant that the Health Insurance Fund was able to align the budget it received from the government with its contracting with providers. That was helpful. However, when it came to the budget execution stage, things did not change. The Ministry of Finance still insisted on approving a detailed line item budget for each provider for the purposes of controlling budget execution. It continued to carry out ex-ante controls in a detailed way of each input line item each month. So providers couldn't reallocate money during the year between line items or between months of the year to respond to needs and demand. And they still had to return unspent funds to the Treasury. So the Health Insurance Fund wasn't very much further forward in creating positive incentives for performance through its provider payment methods. A third stage of reform was made possible in the last few years once the Ministry of Finance started to implement public financial management reform. The Ministry of Finance has taken the first steps towards introducing program budgeting, although it still keeps economic classification as well. But what it has done is reduce the number of input line items in the budget classification and delegated more flexibility and autonomy to spending agencies to shift the budgets, reallocate the budgets during the year. In the case of the Health Insurance Fund, the Ministry of Finance went further and it agreed to a new budget law for the Health Insurance Fund, which delegated responsibility to the fund to control budget execution for health facilities. So the Ministry of Finance and Treasury role in budget execution was largely eliminated, and the Health Insurance Fund was now able to introduce changes in how it executed the budget, which gave it the flexibility to align its provider payment methods and its budget execution. The Ministry of Finance also agreed to allow providers to retain any unspent funds at the end of the budget year. These things created stronger incentives for efficiency in providers, and also create an environment where the Health Insurance Fund over time can increase provider financial autonomy. In practice, the Health Insurance Fund is being very cautious about this. It's not just going to let go of all control over inputs at once, but it has already increased flexibility for providers to reallocate funds across budget line items and across months of the year. What Kyrgyzstan's experience illustrates is that there are several key stages to making provider payment reform for strategic purchasing truly effective. And these same stages also support the objectives of program budget reforms. As well as developing appropriate new provider payment methods, it's important when health financing reform takes place to align budget classifications at the budget appropriation stage and at the budget execution stage, and to reduce rigidities in budget execution. And the next and final phase of reform, which Kyrgyzstan has not yet undertaken, is to build on those stages 1 and 2, and to give more attention to preparing providers to become more autonomous and to developing strategic purchasing to make more sophisticated use of performance-based payment and other instruments for improving health sector performance.
So Alina and Lorraine shared some of the alignments in the budget classification system that are needed to support strategic purchasing, and in particular, output-based payment methods. And so the objectives of output-based payment are to make sure that the payment to providers flows to the priority services and the most cost-effective parts of the health system, and that the right incentives are created to direct provider behavior towards system objectives. So getting the right budget structure is important. Designing and implementing the payment methods to align with objectives is also important. But if health providers don't have the flexibility and the management capacity to respond effectively to the incentives of output-based payment, these incentives will be weakened at best, and they can even become perverse in some cases. So I think this started to come out a bit in the country examples that Lorraine shared, in particular the early part of the Kyrgyz example. But in this part of the session, we wanted to unpack a bit what we mean by provider autonomy and the aspects of provider autonomy that are so important for strategic purchasing to be effective. So we're going to discuss what provider autonomy is and why it's important. And so by this, we mean managerial and operational authority, or the right of health providers to make financial, personnel, service delivery, and other decisions. And we know that the more areas over which providers have these decision rights, the more flexibility that they'll have to respond to incentives. And that's both beneficial and perverse incentives. So we'll talk a bit more about that later. So in this case, autonomy actually amplifies or strengthens the power of the incentives of the provider payment systems. And of course, on the other hand, less autonomy will mute these incentives and make them possibly completely ineffective, and in the worst case, actually distorting. And as with anything, the extremes can also be problematic. Unchecked autonomy can amplify perverse incentives of payment systems. And so we always want to look at complementary strategic purchasing measures to balance out and get the right incentives and the ability to providers to respond, but in a way that is directed towards our system objectives. And we'll show an example of what we mean by this in Vietnam's experience with hospital autonomy. So output-based provider payment systems create incentives for providers to be more efficient. And this means that they will benefit if they can deliver more services with fewer or lower cost inputs, of course, for the same level of quality. And so in order to do this, they need to be able to make decisions in several key areas. So first, they need to have authority over their own budgeting and internal financial management. And this is linked to decision rights about their own internal allocation of funds. Can providers move money around to spend more on medicine, for example, and less on other inputs if that's what their population needs? And this relates to autonomy over recurrent input use, the types and amounts of medicines and other supplies. So if the payment system rewards efficiency, but providers are forced to use medicines procured through an inefficient public procurement system, they may face the pressures of the payment system, but not be able to respond and change their input use. And actually, we could see lower quality of care emerge. And finally, whether and how providers can keep the surplus revenue that they generate from efficiency gains is a really important area of decision rights that affects the power of the incentives in the payment systems. So if the providers are efficient and generate a surplus, but then the surplus is taken back by the Treasury, there's no real reason for them to continue putting effort into generating efficiency gains. And on the other side, if they run deficits and are not responsible for absorbing them, then the efficiency incentives are also muted. So there's some other areas of decision rights that are important for flexibility for providers to respond to payment incentives. And this is the one that Lorraine touched on in the last part of her session, and that is the staffing levels, the mix of staff, whether there is a decision right to hire and fire, and staff compensation, whether providers can set salary levels and bonuses. And as Lorraine discussed, this has been a particularly difficult area to get decision rights for health providers, the public providers, because of this part of the system being governed by civil service laws and regulations that are more difficult for the health sector to influence. Although we do have some examples of countries who've tackled this, as Lorraine shared, in Thailand and in Chile, they have also been able to try to modify civil service laws with particular focus on health sector needs. Finally, other areas of decision rights that matter for the power of incentives are assets and investments. Can providers make decisions to buy equipment, change their space, or other investment decisions? Can they enter into partnerships with other providers, enter into financial relationships to serve populations more effectively and efficiently under the payment systems? And of course, their service mix. If the payment system rewards keeping the population healthy, such as capitation, does the provider have the flexibility to add new preventive services or use their revenue to increase outreach or other more creative population engagement approaches? So these are the main categories that we want to think about when we think about autonomy and what matters for increasing or making the power of provider payment incentives effective. So with autonomy and more control over internal decisions, providers, of course, need the capacity to manage their resources and make good decisions and understand their incentive environments and respond effectively. And these are just very basic, generic areas of management capacity that we sometimes forget to build in and accompany with new provider payment systems. Just overall general management skills at the provider level, the capacity to generate and use data effectively to manage well, both clinically and operationally, and of course, good capacity for internal monitoring and quality assurance. So we want to balance out autonomy with capacity and accountability. So I want to share an example from Mongolia where the country did move towards program budgeting for appropriations. There was output-based payment through the national health insurance system, but provider autonomy was so limited that those incentives were almost meaningless and sometimes actually damaging. So in Mongolia, at the time that this study was done in 2014, hospitals were receiving revenue. These are public hospitals receiving revenue from three main sources: from the social health insurance system through a case-based payment system that should reward activity. The more cases the hospitals treat, the more revenues they receive, and also reward efficiency, that if they could treat those cases for a lower cost than the payment rate, they could generate a surplus. These hospitals also continue to receive some revenue through an input-based line item budget and direct payments by patients. So there's a mixture of both output-based payment and input-based line items. But the Ministry of Health formulated each budget for each hospital based on the projected revenue from these different sources, but then converted into a line item budget based on inputs. And so the revenue, the actual execution of the budget, the disbursement of funds to the hospitals was by line item under a budget cap and with almost no autonomy over the internal allocation of funds. So this misalignment left providers very, very restricted in how they could respond to the incentives. And some of these quotes, I think, were very telling, that if they saved money on food, they weren't able to shift that money to buy medicines. And so there's no incentive, in their own words, there was no incentive or benefit for efficient operations. If they did want to try to make a change because of the changes in the needs of their populations, the process was very onerous. They had to get a budget modification from Parliament. This is at the health facility level. So what the conclusion was here, that the efficiency gains were not only not incentivized, they were actually penalized. And these unused funds were sent back to the Treasury. So Mongolia isn't the only example of a lack of provider autonomy muting or completely blocking the incentives of output-based provider payment systems. In Indonesia's national health insurance system, primary healthcare providers are paid on a per capita basis. They're paid based on the population that they're registered for under the National Health Insurance Scheme. But the use of this capitation revenue by the public primary healthcare facilities is highly regulated. There are many regulations, I think 22 regulations at one count, about how primary healthcare providers could use their capitation funds. 40% being designated for operational expenditures. 60% of these funds could be used to pay fees directly to health workers, but even this was based on certain criteria, education, years of experience, their position, etc. And so even in public primary healthcare facilities that have a more autonomous status, these complicated rules really limited the power of the incentives of capitation. And the providers were sometimes afraid to use this money in case they didn't understand the regulations or in case they were violating them. And so what we're seeing in Indonesia is quite a low rate of absorption of capitation funds in some cases, this money getting sent back to the Treasury at the local level at the end of the year. So the lack of autonomy not only mutes the incentives of output-based provider payment systems, but it can also be an important source of under-executed health facility budgets. So now I want to turn to an example in a country where provider autonomy amplified the incentives of the provider payment system, even when a very small share of the health budget, about 1%, was channeled through these output-oriented payment systems. So in Argentina's Plan Nacer, which is now Programa Sumar since it has been scaled up, this very small share of funding in the system is tied to an explicit benefits package for a priority population. And these funds are transferred to provincial health insurance agencies on a per capita basis, tied to some performance targets at the provincial level. The provincial health insurance agencies, in turn, pay providers fee for service. For every service that the providers deliver in the benefits package to this enrolled priority population, they're paid a fee. The providers have full autonomy over the use of these funds, but with a highly automated monitoring system, routine reporting against performance indicators, so a very high level of accountability. And what we've seen is that Plan Nacer has gotten global recognition for really achieving a lot of outcomes from this very small share of funds going through output-based payment. We've seen actually a significant reduction in neonatal mortality for program beneficiaries. Independent evaluations and anecdotal evidence both point to provider autonomy as a really important factor in the success of this program by amplifying the incentives for providers for even a very small amount of revenue to reach program beneficiaries with covered services. But of course, everything in the extreme can also bring unintended consequences. So Vietnam is an example where hospital autonomy has been taken somewhat to an extreme, and they're dealing with the unintended consequences of that. In 2006, Vietnam started a process to accelerate autonomization of public hospitals. And this was largely to deal with budget pressures during a time of economic difficulty and the public sector having constrained budgets, thinking if hospitals were more autonomous and responsible for generating their own revenue, that would relieve some budgetary pressure. So a ministerial decree divided the public hospitals into 3 categories: fully financially autonomous, partially financially autonomous, and fully subsidized, continue to be subsidized. And so even though they were responsible for generating their own revenue, there was still a lot of restriction on the hospital, how the hospitals could actually use this revenue. How much of it could go to facility upgrades and how much could go to supplementing staff income. But in any case, without any other real restrictions, there were some pretty significant unintended consequences. As you can see from this slide, after the hospital autonomy policy, hospitals began to aggressively increase their revenue, especially the provincial hospitals. The revenue increased about 25% per year and up to 30%, 38% in one of the hospitals. And this additional revenue came to the hospitals by inducing demand from patients. That, of course, led to higher out-of-pocket payments, hospital overcrowding, and persistent deficits for the national health insurance system. And Vietnam is still struggling with these challenges today. So in this case, the hospital autonomy needs to be balanced with more strategic purchasing, more appropriate incentives in the payment system. The hospitals in Vietnam are still largely paid fee-for-service. So there are some more strategic payment systems and other measures to ensure that the services being delivered are appropriate, that there are complementary measures, possibly such as payment caps, to ensure efficient use of these funds. So that, I think, illustrates that the power of autonomy in either amplifying the incentives in your provider payment systems or muting them, or maybe going to the extreme of over-amplifying them and getting the right balance of autonomy, accountability in the context of strategic purchasing. So I'd just like to conclude with some key lessons across the session today on aligning incentives, autonomy, health systems objectives, and the budgeting process. So progress on strategic purchasing, particularly output-based provider payment, often requires accompanying reforms in budgeting and the wider PFM processes. And program budgeting can play a key role, but it's not enough. That has to be accompanied by alignment in classification across all stages of the budget cycle and for all revenue sources of providers. For output-based payment to create effective incentives, providers need to have autonomy to respond to these incentives and make internal resource allocation decisions to be more effective and to actually cover more services but deliver them efficiently. And this autonomy needs to be balanced with accountability to ensure that health system objectives are met.
We hope that you enjoyed our fourth podcast in this series. The next one, now available on our website, is about issues in budget accountability.